Hi guys, welcome to our channel. Today we are going to do the rapid revision of the pharmacology. Pharmacology is a very vast subject which will be comprising the multiple topics and the diseases. So better to stick with only the PYTs and the most important topics. So before we start the discussion, please do subscribe and share with your friends. So let's start our discussion, pharmacology rapid revision. So first thing and the most commonly like 2 to 3 questions are coming from the previous year examinations also. Let's start with the diabetic medications. So diabetic medications, usually our oral hypoglycemics, these drugs are commonly asked with their combinations or let's say their side effects. These questions are commonly asking guys. So let's understand what are the drug class, their mechanism of action and side effects and so also keynotes we will be understanding. So first thing is the drug class. Okay, and mechanism of action and side effects of the drug. So first one is the drug of the choice for the type 2 diabetes mellitus. That is your metformin. Metformin is belongs to the biguanides. Okay, biguanides. What is the common mechanism of the biguanides means? It will decrease the hepatic glucose production. So in the sense of it will decrease the gluconeogenesis. All right, it will decrease the gluconeogenesis, and along with that, it will increase the insulin resistance. Sorry, it will increase the insulin sensitivity. And the best thing about this drug is it will also decrease the LDL. So the combination why we are use the metformin as a type 2 drug of the choice, because it will decrease the gluconeogenesis and it will increase the insulin sensitivity, and at the same time it will decrease the LDL. So commonly the side effects will be nausea, vomiting and GI upset. These are the common symptoms. But if it is in case if the drug is exceeded, then it will cause the lactic acidosis. Okay, this is the commonly asked question. Lactic acidosis associated with which class of the hypoglycemic? That is your biguanides and B12 deficiency. And in case the patient is having the less than 30 GFR, so we should not give the metformin. So at that time, the metformin is contraindicated. Okay, this is the keynote that you have to remember. Okay, next one is the common drugs. This is your sulfonylureas. Okay, sulfonylureas, these drugs are usually glimepiride. These drugs are your sulfonylureas, and high chance these drugs will be stimulating the pancreatic beta cells. So the main mechanism of action is it will stimulate the beta cells of the pancreas so that it will block the potassium cells. So that way it will also again increase the insulin secretion. And what are the side effects? The side effects is usually weight gain and high risk of the hypoglycemia. Okay, this is very prone to hypoglycemia in the patients. This is also commonly noted. And very potent drugs. These drugs are very potent drugs. That's why whenever you are having the patients with the heart disease, in the heart disease patient, you should not give these drugs. Okay, it is contraindicated. So sulfonylureas, your glimepiride, these drugs are your sulfonylureas. And another classification is also there, that is your DPP4 inhibitors. DPP4 inhibitors, you may also heard that GLP-1 agonist. These are also commonly used drugs and very important drugs for our examination. So DPP4 inhibitors, these drugs are your sitagliptin. Okay, all the gliptins, the word which will end with the gliptins, that belongs to the DPP4 inhibitors. Indirectly, it will increase the incretin levels. Okay, there is this hormone incretin, and incretin will on the mechanism of the incretin. If the incretin is increased, it will further decrease the glucagon. Okay, it will further decrease the glucagon and increase the insulin. So this is how the DPP4 inhibitors will be working. And what is the side effects? The side effects are usually pancreatitis. Very rarely present, but side effect is the pancreatitis and nausea, vomiting. Those are the common view. And DPP4s are not renal safe. Okay, whenever the patient is having the renal disease, the DPP4 is not safe. But in some cases, like the drug like linagliptin, okay, the linagliptin drug can be given in the renal safe patients also. So this is the safer for the renal failure patients. Linagliptin only can be given, and these drugs can cause the weight loss. All right, next, moving on to the your GLP-1 agonist. Okay, GLP-1 agonist drugs are your liraglutide. So whichever that end with the glutide, that is your GLP-1 agonist. Okay. And all these drugs are in the subcutaneous form only. And there is this new drug, GLP-1 plus GIP-1. Okay. GLP-1 and the GIP-1 agonist. This is a commonly and nowadays very trending drug, that is your tirzepatide. This is the drug that is newly came into the market. Okay. Now let's go back to the liraglutides, your GLP-1 agonist. This will also indirectly will increase the incretin levels. And further, if it is incretin is increased, obviously what we discussed, the glucagon will be decreased. And if it is glucagon is decreased, insulin will be increased. So this is how the GLP-1 agonist will be increased. Why actually this incretin will be helping? So incretin will actually decrease the gastric emptying. So if the gastric emptying is decreased, further this patient will be having the satiety or the appetite will be also decreased, right? The appetite of the patients will be also decreased. So this is how the GLP-1 receptor agonist will be seen. And same side effects. This patient also having the weight loss and also pancreatitis risk. Okay, and these patients can be given. So this is all the GLP-1 drugs are your renal safe only. The only DPP-4 are not renal safe, but in that also the exception like linagliptin can be given as a renal safe patient's drugs. And now coming to the fifth drug, this is a completely renal safe drugs. Okay, what are those? Your SGLT2 inhibitors. Why these are the very good drugs for your patients, those who are suffering from the renal failure means this is actually the mechanism of the SGLT2 is in the PCT only. So you are actually blocking this SGLT2 so that what happens, there is more and more inhibition of the, so the renal glucose should be absorbed from the PCT. You are actually blocking that. So what happens, the patient will be having the glycosuria. So the more and more glucose will be lost in the urine itself. So that's why you are encouraging the urination via glucose will be lost. And but commonly these side effects will be UTI or the infections like vaginal infection, genital infections in the patients, and patients those who are having the very so much weight water loss from the urine. This can also trigger the DKA and the dehydration. And this is very safer drugs for your renal failure patients and also heart failure patients. And this can also cause the weight loss in the patients. Okay, this is what your SGLT2 drugs. And the examples are your canagliflozin. Okay, the gliflozins, the drug which will be ending with the gliflozins, these are your SGLT2 inhibitors. Okay, next moving on to the drug is your amylin analogs. Okay, amylin analogs. And these amylin analogs, the drug names are the only one which is available in the market, that is your pra-amylitide. Okay, pra-amylitide. This is what the amylin, the name itself telling the amylin. Amylin is nothing but it will also further decrease the glucagon. So whichever the decreasing the glucagon, it is indirectly decreasing your glucose levels in the body. So this is in the subcutaneous form now. This can be given in the type 1 patients and also type 2 patients. Okay, this can be given in the both of the patients. And this is also causing the hypoglycemia because the bioavailability of this drug will be very high, right? So that way, so the hypoglycemia risk is also high. Next classification is your alpha glucosidase inhibitors. Okay, alpha glucosidase inhibitors. These alpha glucosidase inhibitors, the drugs are your acaribos, voglibos, or the miglitol. So these are the drugs, but at least you can remember acaribos and the voglibos. And this is also delay the gastrointestinal emptying. So if the gastrointestinal carbohydrates emptying is decreased, so the absorption is also decreased. Okay, so the carbs main mechanism is carbs emptying or the carbs absorption will be delayed in this alpha glucosidase inhibitors. So the side effects will be usually patients will be having the diarrhea. So due to the decreased reabsorption or the intestinal digestion is very poor. So that's why the patient will be having the diarrhea and also flatulence. These kind of can be seen. That's why this is mainly mechanism in the intestines, right? So never give these patients the drugs in the renal failure patients or the liver failure patients, you should not give these drugs. And also those who are suffering from the inflammatory bowel disease also, please don't give these drugs. Okay. Alpha glucosidase drugs inhibitors are not given in those conditions. Okay. Next, the last one is your thiazolidinides. Okay. So these drugs are your pioglitazone. Okay. So the pioglitazone, the drug which is associated with the glitazones, those are your thiazolidinoids. Okay. Next, what these drugs will be, the main mechanism will be increasing the increasing the insulin levels in the peripheral tissues. Okay. Not on the directly from the beta cells. Instead of that, it will increase the peripheral tissues to increase its sensitivity of the insulin. And how this is going to activate with the help of the PPAR gamma. So with the help of these enzyme, it is going to activate it. And these drugs are completely renal safe. Okay. Renal failure patients, we can easily give these patients. All right. Next, but this is also having the risk of heart failure in the patients. And also there is a risk of edema formation. Okay. So that's why if the edema is formed now, you cannot give in the heart failure patient. If the edema is formed, you're also having a more risk of the prolonged congestive heart failure, right? That's why you should avoid this drugs in the heart failure patients. And also there is some study that have found that pioglitazone can be causing the fracture. Okay. That fracture can be also associated with these drugs. So this is what your basic structure and the basic classification of the oral hypoglycemic drugs and their importance. Next, moving on to the glaucoma. Okay, glaucoma and drugs. Your drug of choice for the open angle glaucoma. So open angle glaucoma, what is the drug of the choice, guys? That is your latanoprost, right? In the latanoprost, what is the mechanism of the action? The latanoprost will be increasing the uveoscleral pathway. So, okay, the main thing is some of the drugs will be increasing the uveoscleral outflow, or some of the drugs will be decreasing the aqueous humor. So this is the main mechanism behind the all anti-glaucoma drugs. These are your prostaglandin analogs. Okay, these are your prostaglandin analogs. Next, coming to the side effects. So the side effects is usually your iris pigmentation. Okay, iris pigmentation will be seen in this patient. Along with that, there will be a high risk uveitis can be formed, and also cystoid macular edema. So the cystoid macular edema will be also seen, and also hypertrichosis. So increased eyelashes, like hair growth of the eyelashes will be also seen. These are the side effects of the prostaglandin analogs. And next drug is your beta blockers. We all know that beta blockers like your timolol. Okay, so the timolol drug, what is the mechanism of this? It will actually decrease the aqueous humor production. So aqueous humor is decreased production by the beta blockers, and the side effects will be associated with the B only. So blepharoconjunctivitis. So this will cause the blepharoconjunctivitis, and it will block the nasolacrimal duct. Okay, it will block the nasolacrimal duct, and also it will decrease the corneal anesthesia. Okay, corneal anesthesia also seen with the beta blockers. Next drugs is your alpha 2 agonist. Okay, alpha 2 agonist is two types of the drugs will be having. One is your brimonidine and the other one is the apraclonidine. Okay, your brimonidine is actually contraindicated in the children. Okay, we'll further discuss why it is contraindicated in the children and why these alpha 2 agonists are used in the glaucoma patients, because this will decrease the aqueous humor, and along with that, it will also increase the trabecular outflow. Okay, so this will be working as a two mechanisms. One, it will decrease the aqueous humor, and another one is it will increase the trabecular outflow. And what we said, it is contraindicated in the children. Why it is contraindicated in the children? Because it will cross the blood-brain barrier. If it is cross the blood-brain barrier, it will cause the apnea, it will cause the depression, and it will also cause the drowsiness in the patients. So understanding all these side effects, we are not going to give this to the patients. All right. And aproclonidine has its own side effects. Aproclonidine will be having the side effects like follicular conjunctivitis and eyelid retraction. These are the another side effects of your aproclonidine. All right. So next moving on to the another drug, that is your carbonic anhydrase inhibitors. This is the drug of the choice for your closed angle glaucoma. Okay, this is for your closed angle glaucoma. What is the drug of the choice? Oral drug. Okay, oral acetazolamide STAT dose will be only given for these patients. And the more of the side effects are the systemic only. The patients those who are having the sulfa allergy, so it is contraindicated. And the patients those who are having the kidney stones. Okay, the patients those who are having the kidney stones also it is contraindicated, and rarely this will cause the any kind of other symptoms in the systematic. Okay, kidney stones, metabolic acidosis, sulfa allergy, that is only seen with the acetazolamide, because we are not giving the through the eye, right? It is a oral acetazolamide. Next, the other drugs are like your pilocarpine can be used, mannitol can be used. These are the other drugs, but the classification mainly focused on these drugs. Okay, please understand and read these two classification for your examination. Next short topic, that is your migraine. Okay, in the migraine, basically what is the drug of the choice? We all know that the drug of the choice for the patients, those who are suffering from the migraine, is the sumatriptan. The triptans is going to be our drug of the choice, right? But these sumatriptan is contraindicated in such situations, such as your coronary artery disease and patients those who are suffering from the stroke and patients those who are having the severe headache. Okay, for example, your SAH. These all conditions now you are not going to give the sumatriptan. All right. Next, other drugs also used. For example, your ergots. Ergots, why not we are giving nowadays means there is a high risk of gangrene in the digital area. That's why the ergot alkaloids are not given. And the common drug is whether we can give the sumatriptan in the pregnancy patients or not. So in the pregnancy patients, especially in the first trimester, you are not supposed to give the sumatriptan. But in the second trimester or the third trimester, so that sumatriptan is safer. And next one is the prophylaxis. When it is comes to the prophylaxis for the migraine, the drug of the choice is propranolol. Okay, propranolol is a not cardioselective drug. So that's why we prefer this drug for the migraine therapy. And another one is your topiramate. Topiramate also can be given, and also amitriptyline, your antidepressants. Okay, antidepressants like amitriptyline can be given in this patient. And the drugs that we are used nowadays, we all know that the monoclonal antibodies are very famous. Nowadays, monoclonal antibodies also developed for the migraine therapy. But most commonly, these drugs are given as a prophylaxis. And another drug also that is very famous, that is your botulinum. Okay, botulinum toxin can be also given for the migraine patient. This is what the migraine therapy. Next, moving on to the ANS drugs, your autonomic nervous system drugs. Autonomic nervous system drugs, they are subclassified into the parasympathetic nervous system and also your sympathetic nervous system. How this sympathetic nervous system will be working? We all know that sympathetic nervous system will be activated only in the situations like stress situations, like your flight and fight hormones. This is are your drugs, right? Your epinephrine, norepinephrine are your sympathetic nervous system. What about the parasympathetic nervous system? These are basically your muscarinic agents, okay? Like your acetylcholine, these are the drugs for your parasympathetic nervous system. Which of the states, like relaxed, patient is taking the rest, those situations only the parasympathetic nervous system will be activated and on. So most of our situation will be parasympathetic nervous system only. Most of the times we are not always fighting, not always in the stress situations, right? So what we do in the normal situation that you have to remember. For that, we have the mnemonic dumbbells. Okay, this is the commonly used mnemonic that we have to remember. So what is this mean by the dumbbell? Opposite to this dumbbell only, the parasympathetic nervous system will be classified. So dumbbell, for example, your defecation. When you are in the stress situation, we not tend to do the defecation or the urination, because in that situation, all are activated, right? And next one is your meiosis. What is the meiosis? Pinpoint pupils. This is your meiosis. And also the patients, those who are having the bronchoconstrictions. This is also due to parasympathetic nervous system only. Okay. And next, bradycardia. MSS means vomiting. So more and more liquid formation or the saliva formation will be seen in the body. All secretions are opened in the parasympathetic nervous system only. And lacrimation. Opposite to this, nothing. The difference will be the patient will be having the constipation, right? Right? Patient will be having the constipation and patient will be having the urinary retention. And opposite to the meiosis, this is what the constriction, right? This will be mydriasis. And patients, those who are having the bronchoconstriction, opposite to that, bronchodilation. Okay, and tachycardia. So saliva will be decreased in this patient, antiemetic. And on the lacrimations, instead of that, the patient will be having the dry mouth and the dry eyes because the secretions will be decreased. Where this is what the main difference between the parasympathetic and the sympathetic nervous system. Let's see classifications of those drugs. First, we see the parasympathetic nervous system. There are some direct agonist drugs and there are some indirect agonists. So parasympathetic nervous system will be activating on the one. That is your muscarine agents and another one is your nicotine agents. Okay, nicotinic agents that is going to be activated and both are mediated by your acetylcholine. So what are those direct agonist and the indirect agonist? So direct agonist are your pilocarpine. Okay, so the pilocarpine, we all know that this drug is given in the patients those who are suffering from the closed angle glaucoma. Okay, closed angle glaucoma. Why we are giving in this patient closed angle glaucoma? This will cause the meiosis, right? If the patient is having the mydriasis, the patient will be having the condition closed angle glaucoma. The iris is already closed. If you do the meiosis, pinpoint pupils will be coming and the decreased tension will be seen in this patient, right? Pilocarpine is one of those drugs. And another one is your bethanocol. Okay, bethanocol, we all know that parasympathetic nervous system is for the secretions only. Bethanocol, what the bethanocol main mechanism is for the activating on the bowel and the bladder. Okay, the patients, those who are in the post-op now. So for those post-op patients, we are going to give the bethanocol. Why? This will increase the defecation. This will also increase the urination. So the bethanocol patients, we are going to use the bowel and the bladder. All right, this is one of the drugs. And next one is your carbon-col. Carbon-col will be increasing the both combination of the action with the nicotinic and also muscarine agents. All right. Next, moving on to the indirect drugs. So indirect agonists are your only drugs that is going to be activated. So usually this is going to block the this will going to block the acetylcholinesterase enzymes. What are those drugs? So if the acetylcholinesterase enzyme is decreased, further it will increase the parasympathetic nervous system and the somatic system. So these drugs are your first one is your donepezil. So this donepezil is a drug of the choice, right? You may have already understand. This is your drug of the choice for the Alzheimer's disease. Patients, those who are suffering from the Alzheimer's disease, we can give this drug that will be having the indirect mechanism of action with the parasympathetic nervous system. And next one is your physostigmine. So this physostigmine is the drug of the choice for the basically for the atropine poison. Okay, so the commonly for the atropine poisoning or the datura poisoning, we are going to use the physostigmine because it will increase the it is blocking the acetylcholinesterase. So acetylcholine is increasing there, right? Next one is your neostigmine. Okay, neostigmine and also your pyridostigmine. So you may already got neostigmine is used for your anesthesia. The patients, those who are having the relaxation, right? These are the muscle relaxants. Okay, and also cobra bites. These patient we are going to use the neostigmine. Pyridostigmine is the drug of the choice for your myasthenia gravis patient. These are your basic drugs and their mechanism of action and their drug of choice. All right. Next, moving on to the atropine poisoning and the organophosphate poisoning. Organophosphate poisoning will be increased parasympathetic nervous system. Okay, so this will increase the parasympathetic nervous system, whereas your atropine will block or decrease the parasympathetic nervous system. That means your atropine will be blocking the ACH. Okay, so acetylcholine will be blocked, whereas acetylcholinesterase inhibitor will be acting here. Okay, so acetylcholine inhibitor will be activating so that more and more acetylcholine will be activated. So this is the basic difference between the organophosphate and the atropine. And what is the symptoms? As we discussed, the dumbbells. So the dumbbell symptoms will be seen in the patients of the organophosphate, like diarrhea is seen, urination, meiosis, and also meiosis, and bradycardia, bronchospasm, lacrimation, salivation. All this will be seen in the patients of the organophosphate. Whereas atropine, opposite to that, the patient will be having the dry mouth, dry eyes, and all the symptoms like decreased urinary retention, or the patients will be having the tachycardia, and patients will be having the hyperemia, mydriasis, dilated pupils. All this will be seen in the patients of the atropine. And what is the drug of the choice? The drug of the choice for the organophosphate patients is give the atropine, because we are actually parasympathetic nervous system is increased. So to decrease that, we can give the drug atropine. But organophosphate is a irreversible inhibitor of the acetylcholinesterase. Along with that, we can give the other drugs like paralodoxim. Okay, this can also be given for this patient. And the atropine patients, we already discussed the drug of the choice for this patient is the pyridostigmine. All right, this is how the atropine and the organophosphate poisoning will be changed. All right, next moving on to the alpha agonist and also other drugs and their drug of the choice. For that, we should also understand muscarinic antagonist. Okay, so what we discussed while ago, guys, the muscarinic agonist, like your direct agonist and the indirect agonist. These are the antagonist drugs. That means these drugs are blocking the muscarinic agents, like acetylcholine will be decreased in these places. Already we discussed here, the atropine is one of the example. So atropine is used which of the situations? For example, patient is having the low heart rate. We can use the drug of the choice for this patient also. In the eye treatment, we can also use this as a cycloplegic. For example, it can work as your dilator of the pupil. So atropine can be used in the patients, those who are suffering from the organophosphate poisoning, low heart rate like bradycardia situation, and also as a cycloplegic. All right, next moving on to the other drugs, like your some of the drugs will be acting on the bronchi. So patients, those who having the bronchoconstriction, to dilate the like bronchospasm, if you want to decrease, what are the drugs you can give? The drugs like your ipratropium. Okay, ipratropium like short acting, or you can also give the tiotropium. This is your long acting drug. Okay, this is your long acting muscarinic antagonist. This is your short acting muscarinic antagonist. Okay, these drugs you can give. And also for the patients, those who are having the eye symptoms, for this patient, you can give the cyclopentolate. And also you can give the atropine. Okay, and also patients like tropicamide, this can be also given. In this patient, there is a question that is asked, atropine is given for the children. Why this is given for the children? Because it is a long acting, more than 1 week it can act, and also it is very strong cycloplegic. Remaining these two can be given for the adults and very short acting only. And that's why atropine is a very much contraindicated in the patients with the acute angle glaucoma patients. Why? Because this is a very strong cycloplegic. It can also precipitate the glaucoma condition. And next, coming to the CNS. In the CNS, we have the drug benzoxol. This benzoxol is used for the patients like Parkinsonism. Okay, those who are having the movements disorders, in those patients we can use this benzoxol. And coming to the urinary system. Urinary system also commonly there is a high chance of the urination. So to decrease the parasympathetic activity, we can use this muscarinic antagonist. What are those drugs? You can use your oxybutynin, Okay, oxybutynin is a smooth muscle relaxant. It will decrease the relaxation and it will also decrease the detractor muscles of the patients. And also some of the drugs like your, which will be ending with the nasing. Okay, for example, your solifenacin and also darifenacin. Okay, the drugs which will be ending with the nasina, these drugs are used for the urinary patients to decrease the urination frequency. Okay, and very much neuroselective drugs these are. Okay, this is what we use in the urinary symptoms. And next, coming to the sympathetic nervous system. In the sympathetic nervous system, now you have to understand alpha actions, beta actions. Okay, when I say alpha actions, alpha one will be activating on the blood vessels. How this is going to activate on the blood vessels? Basically, the vasoconstriction will be occurring here, so that the BP will be increased in this patient. And also other like urethra constrictions can be seen in this patient. Okay, the constriction of the urethra and the blood vessels is mostly by your alpha 1. And next, coming to the alpha 2, this will be decreasing your sympathetic nervous system actions. And if it is sympathetic nervous system actions is decreased only on the CNS, okay, central nervous system sympathetic activity will be decreased. And also it is also used for the vasoconstriction of the blood vessels. Next, coming to the beta, okay, your beta 1 will be having mostly on the heart only. For example, this is going to be the ionotropic mechanism, like increase the contraction, it will also increase the heart rate. Okay, heart rate and the contraction will be by the beta 1. So you have only one heart, beta 1 will be on the heart. Next, coming to the beta 2 will be blood vessels. Okay, this will be activating on the blood vessels, like vasodilations will be seen, and also urinary relaxation. Okay, urinary muscles relaxation is also seen, and this will also activate in the lungs. You have the two lungs, the beta 2 will be for the two lungs. And next one is the beta 3. This is for the lipolysis. It will be on the lipolysis and also for the decrease the urination. This is what the basic functions of the alpha 1, alpha 2, beta 1 and the beta 2, beta 3. This is what sympathetic nervous system, epinephrine and the norepinephrine. And let's see some of the example. For example, let's see epinephrine or the adrenaline. These drug will be having the all actions. What we have discussed right now, alpha 1 to alpha 2 and beta 1 to beta 3. All these actions will be seen by the epinephrine. And coming to the norepinephrine, norepinephrine will be having the only specific functions, not all, but only alpha 1, beta 1 and the alpha 2. And dopamine, so these are also drugs, your inotropes, right? These all drugs are your inotropes. Dopamine for the dopa 1, like dopa 1 receptor, and also alpha 1 and the beta 1. Next, other drugs like your dobutamine. Okay, dobutamine for the beta 1. Okay, these are the drugs that you have to remember and their action. And adrenaline, adrenaline is a drug of the choice for which of the shocks, guys? This is the drug of the choice for your anaphylactic shock. Okay, we give this. And norepinephrine is your drug of the choice for the septic shock. Okay, this is also commonly asked question only. Okay, these are the some of the examples for the sympathetic nervous system, and you have to remember. And dopamine is we usually give for the cardiogenic shock. Those who are suffering from the cardiogenic shock, we can give this drug. Okay, this is what basic introduction with the sympathetic nervous system. Next, we see the non-catecholamines. Okay, for example, alpha 1 agonist. Okay, alpha 1 agonist, we have the so many drugs. Alpha 1 agonist will be so many drugs. For example, you will be having the, you may heard of the phenylephrine. Okay, phenylephrine drug. And also there are drugs like, this is midodrine. Okay, midodrine is used for the orthostatic hypotension. Okay, those the people with the suffering from the orthostatic hypotension, we can give this drug. Okay, midodrine is the drug of the choice. And also alpha 2 agonist. Okay, alpha 2 agonist, this is your clonidine. Okay, and also methyl dopa. Okay, antihypertensive drugs, this is your hypertensive urgency. You can use this as a drug of the choice for the patient. And those who are suffering from the gestational hypertension, you can give the methyl dopa. But methyl dopa will be having the very severe side effects, that is the hemolysis. Patient will be highly risk for the internal hemolysis, right? Clonidine can be given for the drug of the choice for the pheochromocytoma patients also. Because what is the treatment of the choice for the pheochromocytoma? Start with the alpha blockers, then give the beta blockers, then do the surgery, right? This is what we are going to follow the protocol for the pheochromocytoma, right? These are the drugs. And also alpha 2 drugs, alpha 2 agonists, what we discussed again, your glaucoma drugs, right? The brominidine and also apraclonidine. These are the drugs also we can use for the alpha 2 agonist. And also ritodrine. Okay, ritodrine is an your patients those who are suffering from the uterine contractions, severe contractions also we can use this as a drug of the choice for this decrease the uterine contractions. Okay, like smooth muscle only it is going to activate. Next, moving on to the alpha blockers. Okay, these drugs are your alpha blockers. What are those alpha blockers? For example, you will be having the prazosin. Okay, prazosin, tyrosine. These drugs are your alpha blockers. Prazosin is used for the scorpion bite. Okay, and also patients those who are suffering from the hypertension, patients those who are suffering from the benign prostatic hyperplasia, prazosin will be used. And also in the alpha blockers only, selective alpha blockers will be present. That is your tamsulosin. Okay, tamsulosin is a very good drug and also uroselective drug. This is given for the patients those who are suffering from the benign prostatic hyperplasia and also post-stunt placement in the like DJ stunt is placed in the patients of the kidney stones, right? For them also we can give the tamsulosin. This is for the patients those who are suffering from the urinary symptoms and those conditions, right? Next, these are the common drugs that we are going to use. Next, and also you have the other in the alpha blockers only. There is a other drug that is known as a phenoxybenazine. Okay, phenoxybenazimine. This is for the pheochromocytoma patients. Only specifically for the pheochromocytoma, this drug is given. Pheochromocytoma, phenoxybenazine. That like you can remember. Next, moving on to the beta blockers. You all know beta blockers is two types, non-selective and also cardio-selective. All the non-selectives will be starting from the letters of the N to Z. And all the cardio-selectives will be A to M drugs. And your metoprolol, let's say your cardiolol, all these drugs will be cardio-selective only. And remaining all those N to Z drugs are your first generation or the non-selective cardio blockers. For example, your propranolol and also timolol, right? Timolol is your beta blocker for the eyes and propranolol for your migraine prophylaxis, right? These are the drugs. And cardioselective drugs, already I said, cardiolol, all these drugs will be used for the patients with the cardiac symptoms only. And beta blockers is not given, okay? Contraindicated. In which conditions, guys? Never give these drugs to the patients those who are suffering from the asthma. Okay, in the asthma patients, you should not give these drugs. And also patients those who are suffering from the congestive heart failure in the acute stages, you never give these drugs. And also diabetes mellitus type 2, type 1, you are not going to give. And bradycardia patients also you are not going to give, because main mechanism of action is act on the heart rate only to decrease the heart rate. But if you give the already bradycardia patients, there will be a more prone to severe hypotension, the patient can be die. And what is the antidote if there is a risk of the cardioselective drugs? Then that is your glucagon. Okay, you can give the patients glucagon. This is the antidote for these patients. All right. And some of the drugs that you have to know, then like labetalol. Okay, labetalol patients will be having the alpha 1 and the beta. Okay, this both will be acting on the labetalol drugs. And cardiolol. Okay, in the cardiolol, it will be activating on the alpha plus the beta and also along with the calcium channel blocker. So this is what happened in this beta blocker drugs. Okay, and it can be used in the hypertension patients. It can be used in the myocardial infarction, congestive heart failure, arrhythmias, and also pregnancy-induced hypertension and pregnancy-induced crisis. All these spaces we can use. Other uses like thyroid disease, glaucoma patients, migraine patients, and the anxiety patients, we can use these drugs. Okay, next moving on to the diuretics, the PCT. In the PCT, what are the drugs are going to activate here? The carbonic anhydrase inhibitors and the loop diuretics, which will be activating here. So the loop diuretics will be acting here. And next, thiazide diuretics. These thiazide diuretics will be acting on the distal convoluted tubule. And the osmotics will be activating on the loop only. So the loop of Henle, the thick ascending loop will be activating by the loop diuretics, and the other tube in the loop of Henle will be activating by the osmotic diuretics. On the collecting tubule, here your potassium sparing drugs will be acting here. So let's see.
So our first classification will be carbonic anhydrase inhibitor. The drug of the choice is the acetozolamide. And acetozolamide is a drug of the choice for which of the conditions, like you can give in the patients those who are suffering from the glaucoma, and also you can give this drug for the patients those who are having the sudden high altitude sickness. Here also you can give this drug. And these patients, all those who are taking the carbonic anhydrase inhibitor, so there is a high chance this patient can be having the metabolic acidosis, because in the high altitude sickness now you are decreasing the metabolic alkalosis, so that the patient will be having the ventilation problem will be decreased. Further, metabolic acidosis will be increased. And also other side effects like renal stones can be found in this patient. And type 2 RTA can also be risk in this patient. So this is what the carbonic anhydrase inhibit. Next, moving on to our loop diuretics. Loop diuretics, your examples are your furosemide. Okay, this is a drug of the choice for which condition, guys? Heart failure with the pulmonary edema. Okay, pulmonary edema with the heart failure, the best drug that you can use is the loop diuretics. And even other conditions like hypertension also you can give, and also peripheral edema, you can also give the furosemide. And what is this going to do? It will block the potassium, and it will also block the sodium, and it will block the chloride. All this will be blocked by your loop diuretics. So further, it will trigger the all electrolyte imbalance. Loop diuretics will lose all electrolytes. Okay, it will lose the all electrolytes. For example, it will lose the potassium will be decreased, sodium will be decreased, and also patients those who are like calcium, chloride, magnesium, all will be decreased by these patients. Okay, loop loses everything, and also it will worsen the gout. Okay, it will worsen the gout, and it will also be highly ototoxic to the patients. Okay, your furosemide, E for ototoxic and E for ethacrylic acid. Okay, this drug is a very highly ototoxic for the loop diuretics. That's why it is not even used nowadays. And next, moving on to the osmotic diuretics. And in the osmotic diuretics, we have only common drug, that is your mannitol. And mannitol is used for the all trauma patients. Okay, all head trauma patients, we are going to use the mannitol. And also glaucoma patients, we can use this drug of the choice. It has a very two different activity. Where, for example, it will be activating in the trauma patients, it will be activating in the internal circulation of the cerebral vascular. And what about the glaucoma? It will be activating in the eye circulation. And when it is activating in the kidneys, it will be activating in the all the glomerulus circulation. So in the patients those who are suffering from the impending renal failure also, we can give the osmotic diuretics. And what about the side effects? Basically, the side effects of this patient will be having the only the side effects will be the low potassium and the low sodium. Okay, these are only the two side effects that will be seen in these patients. Next, coming to the thiazides. Okay, all your hydrochlorothiazide or the chlorthalidone, all these drugs are your thiazides. And what is the mechanism? It will be blocking the sodium and also chloride, but not the potassium. Okay, potassium is normal only. It will block the only sodium and the chloride. Okay, it is normal only potassium, and it will be activating on your distal convoluted tubule, right? And thiazide drugs are very much used in the patients of the hypertension with the osteoporosis. These drugs can be used in the hypertension with the osteoporosis, and also nephrogenic. Okay, nephrogenic DA also we can use this drug. And patients those who are suffering from the CKD with the hypertension also we can. And side effects of this patient will be increased hyperglycemia. Okay, increased hyperglycemia, increased attacks of the gout is seen in this patient, and also same like that, sodium will be lost, and also your chloride will be lost, and even potassium and the magnesium is also lost. But the best thing is that these drugs are used for the hypercalciuric drugs. So the patients those who are having the hypercalciuric drugs, we can use this hypercalciuric stones in the patients, we can use this drug because it does not cause the sodium, it does not cause the calcium loss in the patients. Okay, that is what we can remember for the thiazides.
Diuretics, that is your potassium sparing agents. And in the potassium sparing agents now, there are 4 types: spironolactone, epileron, and also amilorod, and also your last drug, that is your triamterone. Okay, these are your 4 drugs. And these two, the spironolactone and the other drug, are your aldosterone blockers. Okay, these are going to block the aldosterone inhibitor or the antagonist. Next one is your ENaC channel inhibitors. Okay, these are your ENaC channel inhibitors. What are the uses of these drugs? We can use this drug in the ascites patients. We can use this patient drugs in the Pounds syndrome, and also lithium. The lithium induced diabetes insipidus we can use, and also patients those who are suffering in the PCOS disease and cystic fibrosis disease. All these conditions now we can use the potassium sparing drugs. But what these drugs can be do? Potassium is sparing. So if the more and more potassium is inbuilting in this, so this can cause the cardiac arrhythmias. So highly risk of the heart condition. Okay, that's why this is the side effect, one of the first thing that you have to consider. Okay, next moving on to the other one is your impotence. Okay, impotence, because aldosterone blocker. Indirectly, it can also act on your androgens. That's why this patient can also have the impotence and gynecomastia. Okay, gynecomastia is also seen. All these side effects will be seen with the diuretics. Next, moving on to the heart failure and the drugs that can be having the highly decrease the mortality reducing. So heart failure is subdivided into the acute treatment and also it is given for the chronic patients. But mostly the common asking question, which of the drugs will be decreasing the mortality of the patients? Okay, when it is comes to the mortality, the best drugs are your ACE inhibitors. Okay, ACE are the ERB inhibitors. These drugs are going to decrease the mortality of the patient. And also one of the drugs we all know that is your ARNI, right? What is this drug? That is your sacubitril. Okay, this is your sacubitril with the combination of the valsartan. This is also one of the best drug in the modern innovations of the pharmacology. And beta blockers also very having the very good role, but in the acute stages, it is not going to work. And also your spironolactone and SGLT2 inhibitors. These all drugs are very good. And also you can add the nitrates. Okay, these are the drugs that will decrease the mortality rate of the patients, those who are suffering from the heart failure. And what is the treatment for the acute patients and the chronic patients? In the acute patients, what we can give? We can go for the ionotropes. Okay, we can go for the ionotropes and we can also go for the diuretics. Okay, we can give the diuretics for these patients. And along with that, we can also go for the natriuretic peptide. Like natriuretic peptide, these drugs also can be given. For example, your nasiritine. This drug is given in the acute patients. And how about the chronic patient? All these chronic patients now we are going to use these drugs only. This is what the chronic patients we are going to use. We are going to use the ACE inhibitors, ERB inhibitors, or the ARNI agents, beta blockers, spironolactone, and the SGLT2 drugs. And there is this question: is the digitalis can be the decrease the mortality? And absolutely not. Digitalis is not going to decrease the mortality. So in case even it can be increase your cardiac arrhythmia. So digitalis is not going to decrease the mortality rate of the heart failure. Okay. And next, coming to the other agents and some of the important points of your hypertension is the ACE inhibitors and the ERB inhibitors. And ACE inhibitors, we all know that what are those drugs? Captopril. All the drugs will be ending with the prils. Those are your drugs with the ACE inhibitors. And these all drugs are going to cause the two main side effects. One is the dry cough and another one is the angioedema. And one more thing that you have to remember, ACE inhibitors are contraindicated those who are suffering from the bilateral renal artery stenosis. In this condition, we are not going to give this drug. So ACE inhibitors are not given. And next, moving on to the ERB inhibitors, your all candesartan, valsartan, losartan, all sartans will be your ERB inhibitors only. And these ERB inhibitors, one of the best drug is your telmisartan. Telmisartan is the best drug that we can use in the patients with the diabetes mellitus and also hypertension. This is a good drug because it will be acting on the PPAR gamma, okay, where this is going to be the diabetic mellitus safer. All right. And these two drugs is not given in the patients with the pregnancy also. Okay. In the pregnancy patients, these two drugs are contraindicated. That also you have to please remember. Next, coming to the hypertension emergency. Okay, what does mean by the hypertension emergency, guys? More than 180. Okay, more than 180 by the 100 with the organ dysfunction. Okay, is it the kidney, liver, and also headache, anything that is your hypertension emergency? In these situations, what is the drug of the choice for this patient is the sodium nitroprusside. This is your drug of the choice. Next, moving on to the hypertension urgency. In the hypertension urgency, still same, more than 180 by 100, but no organ damage. Okay, no organ is involved. In this patient, we can give the clonidine. This is the drug of the choice. Whereas in your situations like your pregnancy patients, in the pregnancy patients now, you are not going to give the sodium nitroprusside or the clonidine. In this patient, you can go for the IV labetalol. Okay, this is the drug of the choice for the pregnancy hypertension. Next drugs, that is your calcium channel blockers. In the calcium channel blockers, we all know what are the common drugs, guys. Nicardipine. This is very cardioselective drug. right? This can be given in the patients with a hypertensive emergency also. Another drug is your nifedipine, right? Nifedipine is a drug of the choice for the tocolytics. To delay the pregnancy contractions, we can give this drug. And another one is your nimodipine. Nimodipine is a very cerebrovascular selective. Okay, this is for the brain cases, and this is for the cardiac cases, and this is for the uterine contractions. Okay, to decrease the uterine contractions, we can give the nifedipine. And what is the calcium channel blockers will be doing? It will be blocking the calcium. The L type of the calcium channels now, this will be blocked by your calcium channel blockers. And what are the side effects we can expect? The patients will be having the reflex tachycardia. This is a common we can encounter. And also gingival hyperplexia is also seen. This is also common side effect. And apart from this now, very less side effects with the calcium channel blockers. Next, moving on to our anti-arrhythmic drugs. So anti-arrhythmic drugs will be activating on your action potential of the ventricles. There are 4 classes. One is your class 1, class 2, class 3, and the class 4. How can you remember? You can remember with the mnemonic of the Sonali Bindre, Priyanka Chopra. Okay. S for your sodium channel blockers. Okay, it will block the sodium. And B for beta blockers. P for potassium channel blockers. Okay, it will block the potassium. And C for your final one is the CCP. So subclassification and their specific things if we discuss, your first classification will be again subdivided into the 1A, 1B and 1C. What are those? These 1A, 1B, 1C. Along with the sodium, this will also block the potassium. Okay, both will be blocked here. And in the 1B, only sodium will be blocked, but the potassium is normal. And in the 1C, no effect on the potassium. That is what associated with the third type, 1C. So first class is subdivided into the 3 other types. Okay. And in the 1A drugs, you have this drug of the choice like prokinamide. Okay. Where prokinamide, this is commonly used for the patients with the AFib. Okay, AFib patients we can use, and those who are with the WPV syndrome. Wolff-Parkinson White syndrome also we can use. And another one is your quinidine. This is also one of the 1A classification. And these 1A drugs are very prone to QT prolongation because you are blocking the sodium and also potassium. So QT prolongation is seen with the which type of the drugs? That is your 1A drugs. And also another side effects with the prokinamide, this can also trigger the lupus, and quinidine, which can cause the synchronism. These are the common side effects with the 1A drugs. And in the 1B, we have the only drug that is more famously used, that is your lidocaine. Lidocaine will block the sodium channel, right? That is used as your local anesthetic also. And it can be used also for the patients, those who are suffering from the MI or the digitalis toxicity. Okay, digitalis toxicity also we can use the lidocaine. And lidocaine is commonly same side effects will be seen, which will be seen with the anesthesia. And in the 1C drugs, these 1C drugs are your flecainamide. This is given for the patients with the acute cases of the WPV syndrome. Okay, in the WPV syndromes, acute cases we are going to give. And these 1C drugs are pro-arrhythmic. Okay, these 1C drugs are pro-arrhythmic drugs. Okay, this is what you can remember. And 1C drugs can also increase the Parkinson's symptoms. Okay, Parkinson's symptoms also can be increased with these drugs. This is what the 1A, 1B, 1C classification. Next, moving on to our beta blockers. We all know that beta blockers are commonly your cardioselective, metoprolol, cardiolol, sotalol. All these drugs will be class 2 drugs, right? Okay, in this class 2 drugs, what we give? Basically, we are going to give for the heart rate only to decrease the heart rate control, and also in the acute cases like AFib and A-flutter, these cases we are going to use this beta blocker drugs. And this is not associated with the QT syndrome also. Okay, less chances of the QT syndrome will be seen with the beta blockers. Next, third one is always remember the potassium. When we are blocking the potassium, it can trigger the again QT prolongation is seen. This is also associated with the QT prolongation. One drugs we already remembered, that is your 1A drugs. 1A drugs are more prone to QT prolongation. Again here, the third type of the anti-arrhythmics will be causing the QT prolongation. What are those drugs, guys? Sotalol. You may wonder why sotalol is came here. Sotalol is a beta blocker, but sotalol can be a beta blocker, and also at the same time, it has a very role that it can block the potassium. So that's why sotalol is considered in the classification of the potassium channel blockers. And the famous drug that is your amiodarone. Amiodarone is more arrhythmic, more QT prolongation is caused by this drug only. Amiodarone, again, if you go with the side effects, this is the commonly asked. What are those side effects, guys? Hypothyroidism will be seen in this patient. Okay, hypothyroidism, pulmonary fibrosis is seen in this patient. Corneal deposits is seen with this patient. Liver function test will be damaged, deranged, and also the patient will be having the skin discoloration, especially the blue skin. Okay, these can be seen with these patients. So this is what happens with the amiodarone drug. Amiodarone drug side effects. And this is the best drug of the choice for any arrhythmia. It can be acted as any arrhythmic drug. Okay, it is a very friendly arrhythmic drug. And your class 4 drug, we already said this is your calcium channel blockers. The drugs are your verapamil. Where the verapamil is used when the patients, for example, PSVD patient is came, we are going to give our drug of the choice, adenosine. Adenosine is not usually given in the patients with the asthma. So in this asthma patients, now we can go for the verapamil. So these classifications we are going to use. And also we have the fifth classification also. The fifth classification is usually multiple drugs. Like your adenosine is classified here, magnesium sulfate is classified here, and also ivabride. This ivabradine is also used here as a fifth classification. And next one is your atropine and the digoxin. And if you recall this, adenosine is used for the PSVD patient. Magnesium sulfate is used for the patients those who are suffering from the torsades. And ivabradine for the decrease the heart rate patients. Atropine is used for the bradycardia patients. And digoxin will be used for the heart failure ionotropy mechanism. Okay, these are the drugs that we are going to use in the multiple situations. That's why it is a miscellaneous drugs. And next one is your anti-lipid drugs. Okay, next one is your anti-lipid drugs. What are these? What are those anti-lipid drugs? The most commonly we are going to use is the HMG-CoA reductase. Okay, HMG-CoA reductase. These drugs we are going to use. What are those? All your statins. So the statins main mechanism only block the cholesterol pathway, and this is what the HMG-CoA reductase inhibitors. Your simvastatin, atorvastatin, rosuvastatin, all these drugs are your blocking the cholesterol pathway. And this is used for the patients those who are having the raised LDL and raised cholesterol in the body. Okay, this is one of the classification. And the drugs that are other drugs are like you will be having the fibrates also. Okay, these fibrates. What these fibrates is going to do, especially if there is a triglycerides. Okay, if the triglycerides are more and more, these triglycerides are blocked by the fibrates. So further, it will decrease the triglycerides in the body. Okay, and also it will decrease the LDL and it will increase the HDL in the body. But what are the side effects of this? Usually this patient will be having the gallstone formation. Okay, gallstone formation is seen in this patient, and also myopathy. Okay, myopathy is also caused. And same with your statins also. Statins will also cause the myopathy in the patients. Okay, these are the common side effects. Next one is your niacin. Also, yesterday we discussed the B3 is given in the patients those who are suffering from the cholesterol disorders. So niacin will be decrease the LDL and also it will increase the HDL. Very good combination. Niacin is a vitamin, is a dietary beneficial also, and also it will act on our patients those who are with the cholesterol disorders. But only side effects with this will be flushing. Very rarely seen, but this is the only symptom that is associated with the niacin deficiency. And fourth classification of this lipid disorders are the bile acid derivatives. Okay, the bile acid resins we can also cause. This is also given for the patients those who are suffering from the cholesterol. It will further decrease the cholesterol in the body, and also it will decrease the LDL from the body by activating the LDL receptors. Okay, if it is activated with the LDL receptors, now it will along with the cholesterol and the LDL will be decreased or the gone from our liver. And only side effects for these patients will be the patients are very prone to risk for the gallstones or the any liver disorder. Now this is very highly risk. So, and this is only the safest drug. This is safest drug for the pregnancy patients and also children. This is given for the children and the pregnancy patients. Okay, this is one thing that you have to remember. And the next one is your, and the last one of your drugs for the anti-lipidemics is the PCSK9 inhibitors. Okay, PCSK9 inhibitors, these are your monoclonal bodies. Like here, this is also asked in the last examination of the INICT. Evolocumab, this drug is given for the which patients? This is given for the those who are suffering from the patients of the LDL disorders. So same like that, it will decrease the LDL and also it will decrease the LPLA. Okay, it will decrease the LPLA. This is what the main mechanism of the anticlonal antibody. Okay, next last one is your antipsychotics and the anti-epileptics we are going to discuss today. Okay, antipsychotics is divided into the typical and another one is the atypical. Okay, so when I say typical antipsychotics, this is only going to block the dopamine. Okay, D2 will be blocked here. And in the patient's atypical drugs, now this will also block your 5-HT. What is this? Serotonin, and also it will block the D2. Okay, so the both will be decreased by the atypical. So when I block the D2, there is a high chance of the extrapyramidal symptoms. Okay, these side effects are more prone to typical antipsychotics. And here extrapyramidal symptoms will be very less in these patients. What are those extrapyramidal symptoms? The patient will be having the acute dystonia. Okay, within the minutes, okay, within the minutes or the hours to weeks, this patient will be having the acute dystonia. And in these patients, what we can give, the drug of the choice, basically we can give the promethazine or the benzoxazole. Okay, promethazine or the benzoxazole we can give for the treatment of this patient. And next one is the most commonly side effect, that is your drug-induced Parkinsonism. Okay, the Parkinson is only due to which of the following drugs? That is due to your typical antipsychotic drugs. Okay, this is what happens in the drug-induced antipsychotics. And another side effects is the akathisia. For this akathisia, we can go for the propranolol for the treatment. Okay, this is given for the akathisia patients. And the rare or the late one, like this is a very chronic one, that is your tardive dyskinesia. This is also seen in this patient. What we can do? Decrease the typical drugs, like your typical antipsychotics drugs, you have to stop, and you can change these drugs, change these patients on the atypicals. Okay, only the drug of the choice is you just move to the atypicals one. And last one is a neuromalignant syndrome. So neuromalignant syndrome, you have to give the dantrolene as a drug of the choice. And one thing, like separately, atypical drugs, now these are more prone to some of the risk. So first drug is your clozapine. This clozapine will be having the agranulocytosis. Okay, these drugs can be increase the agranulocytosis and also seizures and metabolic symptoms. Okay, there is a decreased extrapyramidal symptoms, but all other things will be increased in the clozapine and other drugs. Okay, and which of the following, there is a question that which of the following will be increased QT prolongation from the these drugs, atypical drugs? Then you have to choose the ziprasidone. Okay, this atypical drug, the ziprasidone, will be having the high risk of the QT prolongation in the heart. And ziprasidone also have the another role, it will be weight neutral. Okay, so the patient will be not having the weight gain. Here you can see the clozapine is more of the metabolic symptoms, but ziprasidone, Z for zero neutral. Okay, zero weight gain. Like that, you can remember this one. So this is what in the these antipsychotics and side effects. Okay, next your another classification like Next classification is the gout drugs. In the gout drugs, there are two types, acute gout and the chronic gout. Only definition with the between the acute gout and the chronic gout is there is a acute gout, normal uric acid levels in the blood. Okay. In the chronic gout, uric acid levels will be increased. So the drug of the choice for the acute gout now, there is only drugs that we can give NSAIDs, like your indomethacin can be given for this patient. And another drugs like what if it is still progress, then you can go for the colchicine. Okay, colchicine why? Because it will decrease the neutrophil action. So inflammation will be decreased in this patient. So the acute gout treatment will be NSAIDs, first drug of the choice, and second is the colchicine. In the chronic drugs, we are going to move for the allopurinol. This is the only drug of the choice for these patients. Why? This is going to block the xanthine oxidase pathway. So this will block the xanthine pathway, oxidase pathway, and the uric acid levels will be decreased in this patient. And some of the other drugs like your uricosuric. Okay, uricosuric drugs. What are those uricosuric drugs? Your one of the drug is losartan. We already discussed that losartan is a ERB inhibitor, but losartan is also having its role. It will decrease the uric acid from the blood. Okay, and another drugs are like your probenecid. Okay, probenecid also one of the drug that will be more and more urine. In the urine itself, the uric acid will be gone from the kidneys itself. And next one is your rosiburicase. Okay, rosiburicase. This rosiburicase is used for the tumor lysis syndrome. Tumor lysis syndrome. So this is the anti-gout mechanisms and their drug of the choices. So let's have the quick recap from the enzyme kinetics, like from our triple book. You can see competitive versus the non-competitive inhibition. In this, what is the most commonly asked is the what is the Km value and the Vmax value. So when you see the competitive inhibition, so the Km value will be always increased, but there is no change in the Vmax. Opposite to that, there is no change in the Km in the non-competitive inhibition, and the Vmax will be decreased always. So this is what you have to remember. Okay, this drug trials also, when the phase 1 is given, it is only focused on the assessing of the safety of the patient. Okay, this is not using in the patients. This is used for the healthy volunteers. And when we are going to use this on the patients, the phase 2 will be used for the patients. This is for the efficacy and the therapeutic efficacy of the patients. And phase 3 for the efficacy and the safety is already confirmed and the drug is in the market. Next, phase 4 is detect for the rare and the long term, very chronic process for the detection for those drugs. And here you have to remember the cancer chemotherapy. Okay, in the cancer chemotherapy, this chemoman is very useful for our examination. So remember like this only. This C is for the ears. Okay, so drugs like your cisplatin is for the ototoxicity, and also this is a very toxic for the nephron. Okay, this is also toxic for your kidneys. And here you can see this is the only drug that is for the D and T. That is your trastuzumab and also doxorubicin. These both are cardiotoxic. And the next drug is your cyclophosphamide. We always remember, right? The hemorrhagic cystitis is caused by the cyclophosphamide. And these drugs like vincristine will cause the peripheral neuropathy. Your all peripheral nerves will be disturbed by this vincristine, peripheral neuropathy. And the methotrexate 5-fluorouracil and also 6-MP. These drugs will be myelosuppression. So agranulocytosis, cell dysfunction, all this will be seen. These B drugs are for your pulmonary fibrosis. Okay, this is also previously asked question. Next, the last topic. This drug of the choice is very, very important. So patients, those who are coming from the GTCT, like generalized tonic-clonic seizure or the juvenile myoclonic seizure, and also Lennox-Gastaut syndrome, Dravet syndrome. All these patients, we are only going to give the sodium valproate. In the absent seizures now, we are going to give the sodium valproate only because ethosuximide is a very drug that is very costly. It is not available in the any of the India. So that's why we are going to prefer the sodium valproate only. And neonatal seizures, we are going to give the phenobarbital. Febrile seizures, diazepam. Alcohol withdrawal patients, lorazepam, which is long acting. And status epileptic, also lorazepam and the phenytoin. And it is also remember infantile spasms with the tuberculosis, the drug of the choice is vigabatrin. And other drug like infantile spasm, then we are going to give the ACTH. So these drugs Like safest drug in the maternal seizures, that is your levetiracetam, and maternal seizures, eclampsia, that is your MGS4. So this is very important. Go through the PDF also, and some other points also covered. So please remember the pharmacology, physiology, biochemistry. These are going to be a scoring subjects. So should not ignore. Do the rapid revision in this 10 days and maximize your time. And please do access to our new RR notes. This is the best notes that I can recommend for you. And please do subscribe to our YouTube channel. Soon we are going to update the expected topics and the rapid revision of the other subjects.